we know that the bone is a complicated process and there are multiple cells which are involved. So we'll go one by one on that. So as Dr. Alappan was talking about, bone is one which provides the scaffolding. It protects your brain, it protects your heart, it protects your lungs. So it's there everywhere. Without the bone, we cannot move, of course. So it's essential for locomotion. It is also a big store of calcium. 99% of all of our calcium is in the bone. A lot of magnesium is there, and it's the site for production of RBCs, and it also produces hormones like we discussed about FGF23, sclerostin, and rank ligand. These are all produced by the bones in that regards, and very importantly, it plays a role in the buffering capacity. So when you have acidosis, what does bone do?
Increase.
But how does it buffer? So bone will be eluted. When you have acidosis, bone will exchange its ions to ensure that there is a neutrality. The cost of that is that the bone will get eluted. It's like you put something in acid and it's getting removed, and that's why RTA is going to cause your metabolic bone disease. So it's a major site of buffering. Negative proteins will be there in the bone in that regards. Now, one of the most important aspect which we were discussing is about the ability of the bone to keep us firm, keep us strong, and that is the bone strength. Now, what determines the bone strength in alternate way? So, what are the determinants of how strong a bone would be?
The length of the bone.
Yes.
The thickness, cortical thickness.
So, just the length will make them stronger?
No, but longer bones are much more.
So, if you think of it, which will be easier to break, longer or shorter? Okay, longer will be easier to break. So then you're saying you're making a paradoxical statement. So just length is not important, how strong they are. So of course density, that is a common sense, that density is very important. But what we're trying to say is that density is not the only determinant of the bone strength. Can you think of a condition in which density is hugely increased? Yes, the bone can break very easily. So that is the brittle bone. Basically, even though the bone density is too much, it will break very much because every part of the bone is now mineralized from that perspective. So size is a determinant, but that's not a very, very important one. Diameter definitely is, and very important is cortical thickness. If you look at a pipe which is very thin, you may be able to break it easily. If it's completely ossified, it will break more easily. But if there is a sort of a rim-like structure, central cavity, another circle outside, then it becomes very difficult to break in that perspective. Of course, there will be internal components which determine bone density, and the most important one is collagen. So what exactly is osteogenesis imperfecta? So osteogenesis imperfecta is in a way simple way of saying imperfect bone or weak bone right from birth. This is what it means, but most cases are because of the collagen problems. But there are so many other problems that we will discuss about can also cause OI, but essentially this collagen or this matrix component plays a very, very important role in terms of bone strength. But also your calcium and vitamin D play an important role in terms of bone density and bone strength from that perspective. When you say bone mineral content, what does it mean? And how do you estimate it?
The amount of minerals that is
So when you are looking at a DEXA report and it's saying it's BMC, how is it measuring your mass? And what is it a surrogate marker of when you say bone mineral content?
Surrogate marker could be the bone mineral density.
No, it is the marker of what?
Strength, the composition of the bone.
It's a marker of ash weight. So when you burn a bone, all the other components are gone, only the mineral part is left. So that is the bone mineral content. So what they are trying to do is that from DEXA, we are trying to get that bone mineral content in a way, in an indirect manner. So DEXA is not telling you anything, it's just telling you how much bone is there, how much is the area, and from there you are estimating the weight in that perspective and regards. And very importantly, there is also microarchitecture, which is important. So same density, same length, the bones may have different breaking strength. And one condition where this is very important is type 1 diabetes. People have shown that even with a normal bone mineral density, individuals with type 1 diabetes may have weaker bones because the microarchitecture is affected. So that becomes important. So when you are assessing, and when we talk about BMD is just a crude measure. It's only looking at density. You're not getting information about the architecture. You're not getting information about the three-dimensional structure, the cortical thickness, which is also a very, very important parameter to look at in that regard. So which test gives you more information about these parameters and provides you a very, very interesting concept of stress strain index, which is a marker of how much stress that bone can withhold till the time it breaks. So beyond DEXA scan, what is that modality? What exactly is PQCT? So it's actually a CT scan. DEXA is like a X-ray. PQCT is like a CT scan. So X-ray, you are going to get two dimension only. While if you're talking about CT, which is being done at multiple slices and angle, you will get a full 3D image on that. And then you can look at microarchitecture. You can look at the cortical thickness, and you can look at differential trabecular and cortical density, which will give you a good idea from that perspective and regards. So as discussed, bone size is important, but also important is the cortical thickness in that perspective. So diameter and cortical thickness. So if your diameter is more, it will be more difficult to break in that perspective. And of course, bone quality is important. So when we will discuss about bone density, we'll say that DEXA is not your final picture as far as the bone fracture risk or something. Can you think of a condition in which BMD is actually more, but still the fracture rate is more? Not beyond your rare osteopetrosis. A common condition in which the BMD is more, yet the fracture rate is more. Cushing, the BMD is less. Nimisha? Yes. So obesity is the classical example. Their bone density is more. Even if you correct it for their size, the obesity, the BMD may be more. But the amount of BMD may not be sufficient to allow you to basically hold that much weight. The load is also more. So therefore, that is an issue. Second, their volumetric structure and the microarchitecture may be different also in that perspective. So bone, we know skeleton has got very clearly axial component and the appendicular skeleton which is there. And when we talk about bone, there are two major areas, the cortical area and the trabecular area. So cortical bone is one which is in the mid shaft. This is here where that we're looking at. It is the major amount of bone is cortical bone. It has got slower metabolism. So it's got a turnover which will be a bit on the higher side, which will be on the slower side. Much faster metabolism that we see here is at the trabecular bone, which accounts for around 20%. So trabecular bone, what are the sites of trabecular bone, Alapan?
Of the long bone, like scapula.
Yes, vertebral column. So vertebral, more of it is trabecular than cortical bone. So if you want to look at short-term side effects of any therapy or short-term gains of a therapy, you will prefer the vertebral assessment. Classical example, so steroid-induced osteoporosis, trabecular bone will be more affected. When you look at DEXA, do you get information about these parameters? Trabecular bone and cortical bone? So what do you get? If you look at the DEXA report, what are you seeing? You're looking at bone mineral density, you're looking at bone mineral content, you're looking at bone mineral area, but you don't get information about trabecular versus cortical. So what you do for trabecular cortical is to do a quantitative CT scan, PQCT, and you use different sites. So what CT happens is that you will put your hand inside, and if you're using this 4% site of the ulnar radius, you will get information about the trabecular bone. When it goes to 30% side, that is 30% area, you will get information about cortical bone. So if you want to get differential information, you have to do a QCT. But if you look at the spine using DEXA, you will get a surrogate idea as to how much spine is getting affected from that perspective. Now, ossification we know is of two types. One is membranous ossification, which happens in bones like scapula, and the other is the classical endochondral ossification. And most bones will start off with membranous, and the secondary ossification center will be endochondral. So you will have first cartilage which is formed, then the calcium gets deposited, the cells will die, and that is how the process goes. So we know that all the mesodermal derived tissues, be it the fat, the bone, the muscle, the fibroblast, they are all having, and chondroblast, they are all having a common origin. And from there you've got development. So endochondral bone formation is a process that links chondrocytes and osteocytes and osteoblast. So first of all, these chondroblasts will lay a cartilage. On that cartilage, you will have a different type of collagen. So we talked about collagen, and collagen structures are different. The bone collagen is typically which one? So one is the most important, while type 2 is for the chondrocyte. From there, they will then develop into osteoblasts. So osteoblasts are being formed there, and then this will result in deposition of type 1 collagen, which becomes important. And from there, you have got bone formation and bone resorption, which is the bone remodeling, which is done via osteoblast and osteoclast. And finally, you will have ossification, which will require your minerals. Now, based upon that, at different stages of errors, you will have different manifestations. So, Dr. Vibha, what will happen if you have problems in, let's say, type 2 collagen, chondrocyte, osteoblast, type 1, what will be the effect? So, if first of all, let's say type 2 collagen, if it's not there. So, nothing will be formed? So, there will be no cartilage, no bone. Yeah, so we'll go one by one. So if you have type 2 collagen problem, it will be non-viable. No cartilage, nothing, they will die. Yeah. OI, it will cause osteogenesis imperfecta. If there is no osteoblast, again no bone. Yeah. Yeah, so a scaffolding problem. And if there is a problem in the alkaline phosphatase, what is going to happen, Anapan? Yeah.
There will be a very severe early onset gets like manifestation.
So problems in chondrocyte, type 2 collagen, you will never see because they will never be surviving there. Problems in type 1 collagen is what we talk about OI, which we discuss. So that will be seen quickly. Problems even in alkaline phosphatase also are very severe. You can have the perinatal severe form of the hypophosphatasia, which can be lethal, while other forms may be milder also. So that is the whole sequence from that regards. Now, bone basically we discussed has got lot of matrix. Along with that, you have got the calcium hydroxy, and there are other non-collagenous proteins which are there, including GLA protein, and there is also a water which gives a spongy appearance is there. Is there a fat in the bones as well? So there is a definite amount of fat, and there is one medication which converts the osteoblasts into these adipocytes. Can you think of that? And one of the mechanisms how obesity has been linked with decreased bone strength is increased skeletal fat. So that is one. But can you think of a drug which converts bone to fat? Let's put it very simply. It's used for treatment of diabetes. It is an adipogenic drug. So PPAR gamma agonist, basically they will be promoting the adipogenesis. So it will shift the pathway of the stem cell towards the adipocyte pathway. So that becomes important from that regards. So 5 to 10% would basically be your other minerals, 50 to 70% will be calcium, and core collagen will be like 20-30% of the bone structure. Now, very importantly, there are various cells, and we discussed about that there are three major cells. One are the osteoclast, which are eating up, destroying, remodeling. The osteocyte, which is the overall regulator, and osteoblast, which are the bone former cells. So these are the ways these three cells are there. Now, bone matrix, I said collagen is the major matrix, but there are non-collagenous matrix as well, like proteoglycan, glycoprotein, and GLA protein. And these are probably providing an area where you will have scaffolding. So if you look at any of the structures which are made now, they are made on pillars. So these pillars will be there, and on this pillar you will put the cement. That cement basically is your calcium hydroxyapatite. If you want to make a pillar strong, what can you do? So have you seen any pillar being built? So what do they do? So there are multiple rods which are there. Anything else they will do? Along with that, and they cross connect the rods as well. That is very, very important. So it's not just the vertical ones, but the horizontal connections are also very important. So to make this scaffolding strong, you have to connect these particular ones as well, and this is going to make it more important. And there comes the role of pyrrolidinone, which are there to connect that, and collagen ones are basically the initial ones, and then you've got those connections which happen from that regards. So I've already discussed that collagen 1 is predominantly in the bone, plus we have got collagen 5. And for the cartilage, we have got collagen 2, which is the major collagen, and 9 and 10 are there. Now, these collagens are also expressed in different parts of the body, like the ear, like the eye, and therefore they will have important role from that perspective. What is the effect of lack of collagen on eyes and ears in osteogenesis imperfecta? Yes? Blue sclera, that is because of the lack of collagen. So if you understand the physiology, the things will become much easier from there. Now, collagen synthesis, like any other complicated protein, involves a process in which we have got multiple, a large protein. You have got an N-terminal, C-terminal, and then you've got collagen A1, A2. From there, the collagen 1 is cleaved out, and you have got other substances which are produced simultaneously. So, of course, you have got from the C-terminal, which is known as P1CP, and you have got the P1NP. Now, these will be like C-peptide, like copeptin, markers of collagen formation. So if you want to look at markers of bone formation, these are the N-terminal peptides and C-terminal peptides of collagen, which are used as marker of bone formation. Now, these collagen molecules will be dimerizing with each other, and they will be linkage. There is also a post-translational modification. There is addition of lysine and proline, and then connectivity, as I said. From there also, there is a lot of processing which happens, and multiple proteins are working in that direction, including the cartilage-associated protein, the propyl 3 hydroxylase, and cyclophilin B. And then you have got specific enzymes which are going to make these structures more strong. And why are we talking about so many of these? Is that when we use the term osteogenesis imperfecta, it just means weak bone at birth. Till now, people were thinking it is because of only collagen 1 problem, but there are so many problems. Problem in CR-TAP, problems in P3H1, CYP-B, all of them can also cause to ultimately your collagen is not going to be strong enough. So it's not just a problem of collagen. There are multiple scenarios which are there, and these sort of genetic disorders are known as when multiple genes are regulating similar phenotype.
Multiple genes are regulating similar.
Multiple gene defects have similar clinical manifestations. Yeah, so it is not the oligogenic. Oligogenic is a different thing altogether. So here, any of them are defective, you will have the same problem. Oligogenic is that you need to have multiple defects to get that particular problem. That is the major difference. Okay, so there can be so many problems, and different types of OIs can be caused by that. Like you can have a problem in 5-alpha reductase, you can have a problem in androgen receptor, 17-beta HSG, LHCG, they will all cause XYDHD. So that means all genes ultimately have the same phenotype. So here all the defects have the same phenotype. So you don't need to remember that, but remember that now there are multiple 20, 30 types of OI, and every time you will read, there will be new types of OI which are being developed. Now, type 1 collagen is largely in the bone, but it's also in the skin. So, skin laxity, when you stretch their skin, it becomes quite lax. Teeth, so dentigerous imperfecta. So, always examine the teeth of a child who comes to you with bone fractures to look for whether there's a dentigerous imperfecta. Blue sclera, muscle also can become weak, and of course, hearing, which is very, very important for OI from that perspective. Beyond collagen, there are other non-collagenous proteins, particularly proteoglycan, which is known as aggrecan. And aggrecan problem is a very unique type of short stature. What is unique about aggrecan defect? Yeah, ACAN gene. Yeah, so what is the problem in that? Yes. So everybody who has got short stature, you expect the bone age to be retarded. ACAN mutation or AGRICAN mutation, you have got advanced bone age. So that is the unusual scenario. So they have a double whammy in that they have limited time to grow also from that regards. Then glycoprotein provides cell-to-cell interaction in the form of COMP. That is the cause of what is known as quote unquote pseudoachondroplasia. GLA protein is a bone formation marker, and osteocalcin is important, and there are sibling ones as well, which is osteopontin. So there are multiple proteins there. So what I'm trying to say, I'm not trying to confuse too much or giving too much information. What I'm trying to say is that there are multiple defects which may happen in the matrix area, and that's why you've got so many types of OI, so many types of chondroplasias in that